And again, anybody who is unmuted, please mute yourself. Thank you. We're gonna get started. Good morning. My name is Jeffrey Hogan. I'm the president of Upside Health Advisors. We are very grateful to have the opportunity to speak with all of you today to discuss ways to promote care transformation and supply chain competition. Yesterday, we met with stakeholders, the labor groups, to discuss the opportunity to partner with high performance health systems, providers, and point solutions to find a more efficient way to achieve superior outcomes and to improve access. I'm going to introduce my team in a second. And again, please mute yourself if you are unmuted at this point. Really welcome the opportunity to speak with you today, and we'll have the opportunity after this meeting today to answer questions and to interact with you directly. Go to the next slide, please.
Oh, I apologize.
So I'm really pleased to introduce the members of our team to you today. You'll have the opportunity to hear from most of the team today relative to our findings and observations in different parts of the presentation. I'll start with Brian Clepper, who is a nationally known healthcare analyst and consultant who comments specifically on high-performance healthcare organizations and is very focused on value-based healthcare. I'd also like you to meet Dr. John Rodis, who is the past president of one of Connecticut's highest performing hospitals in RAND, both for cost and quality. He headed up the quality committee. Could folks mute themselves? Can you do that, Nick? Can you mute everybody? Thank you. We can get back to it. Dr. Rodis headed up the quality committee for the Connecticut State Hospital Association. Can we go back to the other slide?
Absolutely.
Okay, thank you.
No, not share.
Up top.
Oh, I'm sorry.
Yeah, there we go. He's a value leader nationally, and he's particularly focused on healthcare quality and safety. And he'll be talking specifically about healthcare transformation and New Jersey specific data today. Christine Arnold has been in healthcare for over 2 decades and has worked in every aspect of the healthcare ecosystems. Along with me, was one of the founders of the Connecticut Moving to Value Alliance, a big tent group of hospital systems, providers, payers, consultants, and purchasers looking to move from fee-for-service into value-based healthcare. Personally, I've been in healthcare for 35 years and work nationally with high-performance provider organizations, health tech startups, and large purchaser groups on moving to value. Next slide. Just a little bit of housekeeping before we get started. I'll ask that you hold your questions to our breakout groups that have been scheduled for this afternoon. Again, please mute your line if you're on. And really what we're going to ask you to do today, if you will, is to listen to some of the findings and recommendations. This is really an opportunity, an ask, if you will, to high-performing provider organizations and health systems like yourself to think about how you can partner with the state to achieve superior outcomes and access. We're really grateful for everyone who has attended today, and the session is being recorded and will be available as well. Nikki, this afternoon for breakout groups, anything you want to say about that in terms of scheduling for breakout groups?
Absolutely. So there are 2 breakout rooms that are scheduled. One this afternoon was sent to our point solutions, and there is another one sent to the providers. These invites were sent by Kristen Deacon. If you do need to have this invite sent again, please put a note in the chat feature, and I'll make sure that we send the links to the appropriate breakout rooms.
Very good. Okay, if you could advance. So we want to lay out a little bit of healthcare context to set up our presentation today. Next slide. Nationally, healthcare consumes nearly 18% of our GDP. It's likely not an unknown fact to you, but that number continues to grow fairly dramatically and uncontrolled. And almost half of the American population receive their health insurance via employer-sponsored group plans. 2 specific items that are of particular concern to us, and I'll talk about our engagement in just a second to lend some context. But we're finding, just like the rest of the country, specialty drugs represent about 50% of all pharmacy claims, nearly $400 billion in the case of the state of New Jersey. About 2.3% of the population is responsible for the consumption of specialty drugs on the PBM and the med pharmacy side. And it's a particularly large item of focus, if you will, a focal point that we'll talk about in a couple minutes. So really the main reason that we're here today to talk to you and to potentially ask for partnership is this whole issue of cost. Healthcare costs are increasing at basically an unsustainable rate. When employees look at their wages and then they look at what they have to pay or contribute toward their health plans, health plan costs are just rising at exponential rates, if you will, exponential in relation to the inflation that we're experiencing. Next slide. Specific to New Jersey, we're talking about 9.4 million people in the state, and the state health plan spends about $5.7 billion on the state employee health plan, covering roughly 822,000 active and retired beneficiaries. And it's not just in the state of New Jersey. Obviously, retirees go to other places as well, and we'll talk about that as part of our presentation. New Jersey has 113 hospitals, including specialty, 72 of which are acute care locations. And again, we put this in specifically for New Jersey. Specialty drugs account for approximately a third of the state employee health plan spend annually, and a particular focus for us here. Today, we'll talk about primary care and advanced primary care a lot. A number of the organizations that are on this call listening right now are primary care oriented, and there's a huge opportunity here for primary care, specifically in New Jersey as elsewhere. But a study that we used from the Primary Care Collaborative found that New Jersey had one of the lowest primary care investments for the broadest definition of primary care, 6.38%. So this is surveying every state in the union as well. Next slide. So really the theme of our presentation today is intentionality, the intention of the state and its stakeholders to do things differently to improve on cost and quality variation, outcomes, and access. Next slide. So I'm going to talk about some of the initiatives that have occurred. Again, proposing this intentionality on the state level from a political point of view. I think it's really important, though, to point out that our engagement, which I'll talk about in a second with the Division of Pension and Benefits, the Division of Pension and Benefits independently have been focused on this whole notion of care transformation. Many of you have been involved in that, if you're a point solution and what have you, and really looking closely at this whole notion of moving to value. Many people don't know what moving to value actually means. My colleague Brian Clepper shortly will go into a more macro description of what value-based healthcare looks like, should do, some of the tactics that are involved. And then my colleague, Dr. John Rodis, will also opine specifically on the opportunity for New Jersey as well. So just to start out, the State Health Benefit Quality and Value Task Force had some specific prioritized initiatives. So in 2018, Governor Murphy convened the task force to focus specifically on the quality and value of healthcare for the state. And unfortunately, when it comes to value-based healthcare, often quality and value are esoteric notions or opaque notions. We're going to try and remove some of that opacity today to talk about specific tactics. The charge of the task force was to identify both short and long-term solutions to improve the system. And we're certainly going to talk about that opportunity today. Other states have tried to do things like this. Some have been successful, some have not. We'll actually point to a study that just came out in June that surveyed 50 states and their initiatives around these types of things and documents their success and failures as well. The task force members were made up of representatives of various broad constituent groups. Next slide. So I chose this quote specifically for this presentation, and I think it's important for anyone who's on the call really to read this quote. The task force recognizes, and this is the word I think that's most important, the urgency now more than ever to explore and embrace, and this is another great word, the opportunities presented in this report. Again, it's the reason that you're on this call today to say, hey, I think I can help to grasp that opportunity and to move toward some of these better outcomes and access points. So some of the things that were touched on in the task force, and you see the description here, payment reform, including direct contracting, value-based contracting, improvements in hospital efficiency and safety. And Dr. Rodis shortly will talk about the fairly significant variation in cost and quality, which is not unique to New Jersey. It exists across the country. Vendor partners who share the state's vision for a better model, using episodes of care or other incentive-based payment models. So we help to work on such a thing in the state of Connecticut, where the largest purchaser in the state of Connecticut, actually has moved to a value rubric, which we'll talk about shortly, using targeted price and warranted episodes of care. That will be part of our discussion. Improved access to care, obviously coming out of COVID, this is a particularly important thing. Ongoing and consistent data analysis. As I mentioned before, advanced primary care and care coordination, nuanced care paths, integrated care solutions, steerage, longitudinal care coordination to high performance providers, the integration of behavioral and better behavioral access, a keen focus, not just on better clinical outcomes and integration, but on predictable clinical outcomes, both on the cost and quality side. And this very broad notion of the removal of waste and inefficiency. Next slide, please. So another prescient quote, despite the progress we've made, healthcare costs continue to be challenged. Healthcare workforces come together. So there's a recognition, and I want to point it out here because there are hospital systems that are on this call. Again, Dr. Rodis ran a hospital system as well in the middle of COVID. The frontline workers and the hospital systems who have suffered through COVID and potentially are about to suffer through another stage of it are really quite heroic. So acknowledging what the health systems have had to put up with and dealt with throughout the epidemic. But now the whole notion is to build on this spirit of moving toward a transformed healthcare system to make it more equitable, accessible, and affordable. And in a couple of minutes, I'm going to talk about what happened with COVID, both from a provider point of view and from a consumer point of view, from a patient point of view, to change some of the expectations around how healthcare will be delivered in the future. Next slide. So an executive order 217 that was issued in January orders the Department of Banking and Insurance to develop plans for healthcare growth benchmarks. So this is something that has occurred in other states, and there's some coordination around this whole notion of healthcare cost growth benchmarks. The Milbank Foundation is working to help coordinate this whole initiative, and health insurance affordability standards that establish healthcare affordability groups. So number one point, access to quality and affordable health insurance. So this access thing is really important. Again, we'll talk about that coming out of COVID. Why is access and patient engagement suddenly such a thing of high importance prioritization? Point two, the whole notion of prescription drug cost growth. And I think it's not just prescription drug costs. We've looked at the state's data. We'll be talking about medical pharmacy as well, efficacy related to drugs in general. Inequities in health outcomes, that's the variation in cost and quality. This whole area of care coordination and patient engagement. So getting away from fragmented care and moving more toward integrated or accountable care. We talked about the healthcare cost benchmark a little bit. And point six, affordability and transparency. These are obviously major concerns to the stakeholders, those that the care is delivered to here in the state of New Jersey. Next slide. So this is a really important point. Why now? Why has the Division of Pension Benefits prioritized the movement to value? Why independently have they been focusing on this even prior to COVID? But really, COVID has reinforced or accelerated this prioritization of care transformation as a primary goal. It's really because we've seen some failures and deficiencies in the current system. Our expectations have changed, and there's a belief that there is a better way. Certainly, it doesn't mean that the state won't continue to work with its current partners on the health plan, but there's a likelihood that they'll work with them differently. And I think that's an important theme for this discussion. If we look back to the end of March last year, many of you on this call realize that unless you were providing COVID direct services, many provider groups and even large parts of health systems were laid off. Did not have volume coming in, didn't have access to patients. Patients were hiding in their homes. And many of these provider groups did not have access to patients. It really did show some weakness. And many provider groups, most provider groups and most health systems felt an existential threat to their existence financially. Fee-for-service demands volume, and when that volume went away, it really created some problems. Not only that, but it created problems in access. Some organizations had access to telemed platforms, others didn't. Some had to bring them up, others set up virtual care platforms that weren't interoperable. And in the meantime, patients in their homes, especially polychronic and comorbid, didn't have really great access. And clearly, it has changed expectations around what people want from the healthcare system, how they want to be treated. And we've seen something of the birth of the unicorn, the healthcare consumer, that thing that hasn't existed in the past suddenly seems to be inspired. Billions of dollars have come into health technology. We'll talk about that in a couple of minutes. And in many ways, legacy provider groups are now using health technologies to look larger, to provide that access, to coordinate care in a different way. There seems to be a priority, an opportunity to move toward care transformation and to meet these new expectations. Next slide. So the statement of work for what we were asked to do, basically, next slide, via the state of New Jersey Department of Treasury Division of Pension and Benefits, engaged our organization to review the state's health benefit plan's current performance and to devise and propose a value-focused strategic and tactical roadmap that can measurably improve results and enhance outcomes and lower costs. Again, about 822,000 beneficiaries, including employees, retirees, and their families, and roughly a $5.7 billion annual spend in 2020. Next slide. So who did we talk to? Who did we work with? Where did we get data? Who were the various parties that we were given access to and had the opportunity to work with? Obviously, the stakeholders, the labor groups. We spent quite a bit of time assessing their needs and desires and wants and concerns. And obviously, the stakeholders are concerned about burgeoning costs and pressures on their members, not just from a cost share point of view, but from an access to care point of view as well. Also for the future, stakeholders and their benefits. There's a concern about unfunded pension and healthcare retiree liability, having those benefits in the future and what they'll look like. The stakeholders have a vested interest in controlling the costs of care and the variation in cost and quality as well. And we spent a full day with them yesterday. As I said, moving to the right or clockwise, the Department of Treasury, the Division of Pension and Benefits, gave us great access internally to talk about the independent initiatives that they've had to look at these problems and these issues and to convey to us some of the obstacles as we're devising a roadmap. Consultants and partners that the state of New Jersey works with had the opportunity to interact with them and to look at data coming out of these areas. And certainly with providers and point solutions, we've had the opportunity to look at some of these point solutions both under the existing health plan and run independent to the health plan to make our assessments. Next slide. These are some of the resources, and at the end is a more comprehensive listing of all the resources that we've been using with hyperlinks to those resources as well. But the RAND Hospital Transparency Report 3.0 and a New Jersey RAND analysis, which is specific to the state of New Jersey, were really critical to our analysis. As I said, Dr. Rodis will have a larger section in this presentation presenting results there. The analysis of data from Horizon, Optum, and Aon and obviously the State Health Benefits Quality and Value Task Force report as well. Next slide. So this is just a word salad, and we decided to put this together because we find anytime that there is a discussion or a presentation around healthcare, it tends to be fairly wonkish in its language. And the value-based healthcare world certainly has its own vernacular as well. Certain aspects, features of value-based healthcare that are particularly important. I will point out one word in here that you'll see that we're hyper focused on, and it's in the middle of the word salad, and that word is predictability. The whole idea here is that if we can help to enable a reduction in variation in cost and quality and create accountability, we can also create predictability. As I was mentioning, the state of Connecticut Employee Health Plan has moved to a closed loop of accountability, which uses attributed at-risk, tech-enabled advanced primary care, steering agnostically to high-performance providers, specialty providers, health systems that offer targeted price and warranties for episodes of care. It creates a very predictable paradigm. Is it hard to get there? Yeah, yes it is. But we have data to show us the performance of not only health systems, specific hospitals, but the service lines within hospital systems, which are extruded from all payers claims databases and other data sets to show us the opportunity to partner with organizations like yours to create predictable costs and outcomes. Next slide. So we'd like to frame this in a specific way using guiding principles, quadruple aim principles related to care transformation. The whole notion of achieving superior health outcomes, again, not as an esoteric goal, but as a real, tangible, and predictable goal, whether it's on MSK or cancer or cardiometabolic. And you'll see in a few minutes where we even talk about drugs, creating efficacy around drugs so that the endpoints or the goals for the drugs create superior outcomes, viewing a drug as an episode of care, controlling costs, obviously, clinical satisfaction, which might be clinical integration, and an enhanced patient experience. What does that mean? Much of what we're seeing now involves this new health consumerism, the new expectations of patients about how they'll be treated, both in person and virtually, including patient-reported outcomes, using net promoter scores to evaluate how people are treated and how they feel about the way that they're treated. Even as organizations are going through this care transformation analysis to see if it's right for them for episodes of care, using things like Professor Porter and Kaplan's time-driven activity-based costing to see how to achieve best practice and targeted price outcomes. Next slide. So this is a particularly important slide. Is there a panacea for achieving these goals? Do we think that there's one way to get there? And the answer is no. So the problems that exist in our system were not created overnight. They weren't created by one group, and everyone needs to be part of the solution. That is the reason for this meeting today. Invitations were sent out. The thought process is that there are really good provider systems, health systems, point solutions. Many of you are on this call today who perhaps see a vision for showing how good you really are in creating this accountability. We don't live in a perfect world. So I mentioned this before, number 2 up here. You're not alone. Many states are trying lots of solutions. So one of the reports that's in the appendix of this presentation came out in June from the Center on Health Insurance Reforms. It's called Unleashing the Giant: Opportunities for State Employee Health Plans to Drive Improvements in Affordability. And again, it surveyed all 50 states. This just came out in June. It's a really good report. It shows failures, lots of them, and successes as well in trying various types of initiatives. And I encourage all of you on the call to take a look at it. We need here, and there's a belief and there's directionality from the stakeholders, from the division, from others, and I think from many of you on this call, to focus on what matters most, finding those things that have the greatest effect on access and outcomes. And there's a collective belief that there is a better way. Next slide. So we used an analogy, and in our statement of work, we talk about a roadmap, and I'd like to use this metaphor or analogy in a little bit of a different way. And coming off of what we just said, there are many ways to get to places, and I'll use a play on words there. You know, many of us tactically navigate from place to place. We don't use paper maps or road maps anymore. We use crowdsourced apps like Waze. And, you know, I'd like to think it's a more appropriate analogy from getting from here to there. We know, whether it's in New Jersey or Connecticut or Maine or North Carolina or wherever it happens to be, that there are different health systems, there are different stakeholders, there are different impediments to getting from place to place and navigating to something that is better. We fully get that. We also see nationally success with a model, and I've put some of those elements on here just to show it, where we've used attributed tech-enabled advanced primary care, steering to high-performance providers to get those better patient-reported outcomes. In some cases, it's involved direct contracting, using an appropriate risk progression path, not unlike, let's say, the new CMMI direct contracting model, potentially using episodes of care. This whole notion of the digital front door, improving upon legacy brick and mortar organizations by partnering with health technology for the patient to take them through a patient experience. When a patient leaves the provider, that there are mechanisms to coach them, to integrate with them, and to get data back to providers as well. We see it all around us. We'll use some examples after Brian Clepper does his presentation, and Dr. Rodis, I'll certainly cite some of these examples as well. And then, you know, that big thing that we have here, the big opportunity, certainly specialty medications, this whole notion of getting hold of specialty medications and improving on not only efficacy of the drugs that are written, but making sure that the drugs actually work to produce superior outcomes. Next slide. So it's my distinct honor to introduce my friend and colleague and nationally known commentator on value-based healthcare, Brian Clepper, who's joining us remotely. And Brian, the floor is yours.
Good morning, ladies and gentlemen. I'm Brian Clepper, and I am working with Jeff on a number of projects, all of which have to do with value. And my role here today is to describe to you a framework for of emerging healthcare value nationally that can be potentially very powerful. As a place to start, we want to point out an equation that was offered by Dr. Porter from Harvard. Jeff referred to him earlier. He wrote an important book on healthcare value in 2007, I believe, which is a long time ago already. And the equation says that healthcare value is equal to quality divided by cost, quality per unit cost. So if you improve quality, healthcare value goes up. If you lower cost, healthcare value goes up. And that's a core explanation. The second point here is that what this means is that a value-based focus on healthcare independently considers and balances healthcare quality, patient experience, and cost. You're not just looking at what is the cheapest care, or what is the best quality care, what's the best experience. You're looking at all of them and balancing them in a balancing act. Let's go to the next slide, please. There are the second big definition that I want to describe to you is what we'll refer to as high performance healthcare. Every vendor says that they're high performance, of course, but the proof is in the doing. And it's useful to talk about the characteristics that define high performance healthcare. High performance means that a vendor consistently delivers better health outcomes and or lower cost and or better patient experience than conventional approaches, particularly in high value niches. And here we're talking about the areas where the money really is, places like musculoskeletal care, cardiometabolic care, management of chronic disease, cancer care, management of drugs, management of high cost claims, and so on. Paying a lot of attention to that. What has happened over the last few years is that there has been an explosion in companies that have focused on doing a much better job within some niche of healthcare, and those are the vendors that we're very interested in terms of consideration and an opportunity going forward. Examples, if you take all the people who have developed these new companies that get such powerful results, and I'll give you an example of the results in a minute, and you dissect them, what you notice is that they all look very much alike. They are, independently of what they're focused on, they all are passionate and mission driven. They're data and evidence driven. They have very high subject matter expertise in some niche, and they have identified some particular problem within that niche and deconstructed it and come up with an entirely different solution than the prevailing one in the marketplace. And then over time, they tinker with it and they become so intimate and familiar with it that they're always willing to put their fees at financial risk against the performance targets they think they can achieve. It's a remarkable thing, and I've seen it over and over again. the kind of thing that I'm talking about here, for example, there is a musculoskeletal management firm that I'm familiar with that has developed an entirely different approach to management of musculoskeletal conditions. Musculoskeletal is 20% of group health cost and about 65% of occupational health costs. It ends up being about $1 in 4 in US healthcare spend. And there's an entire literature showing that about half of everything we do in orthopedics is unnecessary and inappropriate. This group now is working with major corporations, and the data show unequivocally that they get way better health outcomes, pain reduction, range of motion, activities of daily living in half the recovery time and at half the cost of conventional orthopedics. They are willing to offer their clients a 25% cost reduction guarantee, along with a guaranteed improved result on key quality health outcome measures. So it's very strong. What that 25% reduction translates to is a guaranteed 4 to 6% reduction in total healthcare spending, or more likely, an 8 to 12% reduction in total healthcare spending, because what they're willing to financially guarantee is based on half of what they know that they can achieve. So we're talking about organizations that are bringing dramatic new value to the healthcare marketplace, and they represent an opportunity to move forward. That brings up the question of what questions do you ask of the companies that are coming to you to try to decide whether they are in fact high performers. Well, the first thing you want to know is, can they show you credible data demonstrating they consistently get better health outcomes and or lower costs measurably and over time. The second thing you want to know is can they give you client testimonials and let you talk to the people who gave those testimonials, so that people who have worked with them previously can tell you directly that they are able to execute and do a good job in the process. Are they scalable? It's really great if they can get great results in Austin, Texas, but can they get great results in Trenton, New Jersey, or Denver, or Providence, Rhode Island? Are they sticky or enduring? It's really great if they get tremendous results after 3 months. Are they still getting tremendous results after 3 years? And can they prove that? Another important question is, how do they integrate into the existing healthcare management ecosystem? I mean, if they're a standalone module and they can't move seamlessly into place, so that they're functionally invisible to providers, they'll be very disruptive in not such a good way. And then the final big question is are they willing to make performance warranties or guarantees? Are they willing to put their money where their mouth is and financially guarantee that you will get better health outcomes and or lower costs, whatever the case may be? Hugely important. The key elements of value that we've been able to identify.
Excuse me, Brian, I think you are breaking up.
Advanced primary care, and what that means is not simply primary care as we have seen it over the last 30 or 40 years, but primary care that, in addition to looking in ears and and sort of trying to figure out what's going on with every patient. It's primary care that becomes a platform to manage the clinical and financial risk all throughout the continuum of care. So in other words, you use primary care to control downstream what's going on with care and with cost. Direct contracting is a great way to get there. Direct contracting is very important because the health plans over the last several decades have boxed in primary care. They have said, we're going to decide which doctors take care of our patients and how much we're going to pay those doctors for each service. And they have ratcheted down the amount of money that primary care gets for doing what it does dramatically. And so as a result, primary care started doing more visits per hour and doing less to patients during every visit. So patients ended up getting referred much more frequently downstream. And in the process, healthcare costs went up and health plans made a lot more money because they're making a percentage of the total. Direct contracting by advanced primary care, going and contracting directly with employers and unions and other groups that are at risk for healthcare, is a much more effective way to take control and to do what needs to be done. Bundling is an important function that has really begun to come into its own. It's instead of breaking a procedure like a surgery down to all of its most discrete elements, it says, what is an all-inclusive price, and what are the quality metrics that I need to understand so that I can do this all in one group, and I can compare the performance of cost and quality across vendors for the same thing. That's been something that's been very difficult to do until now. Bundling makes that possible, and it allows us to, it works to the advantage of patients and purchasers in a new way that they should be demanding. Performance transparency is critical. Currently, employers and unions face tremendous challenges working with health plans and TPAs in getting access and control of their own data. In the new marketplace that we're seeing, the most successful organizations are demanding unlimited, timely access to all health plan performance data so that they can analyze it themselves and come to their own conclusions without being impeded. Outcomes and performance guarantees, I touched on this before. It makes no sense whatsoever to say, I will just pay you whatever amount of money you ask for to do a particular service for me, and you're not offering any guarantees. Require vendors to be held accountable, and specify the metrics that are associated with that, and that's a critical element of moving forward as well. And finally, vendor reimbursement that is tied to performance. One of the critical elements that we believe needs to happen is that relationships with vendors need to be fair to vendors who perform, pay them more if they get excellent results, and align the interests between the vendors, the purchasers, and the patients. I think that provides a broad frame, and with that, let's move on to Dr. Rodis. Thank you very much for your time.
So I'm going to do a quick introduction here again. This slide is important because the topic is the most important part of our presentation today. That variation in cost and quality drives pretty much everything in healthcare, and that's our primary focus here today. So our desire was to bring credibility to this presentation, and again, Dr. Rodis is in OBGYN, president of a hospital. He's been a medical director in the past, and he's shown tremendous initiative specifically in Connecticut around quality and performance. And with that, we've asked Dr. Rodis to do some analytics on the RAND data and other data for the state of New Jersey specifically. And I'm very pleased to introduce Dr. John Rodis to you all.
Thank you, Jeff. And good morning, everyone. Happy to be here. Sorry I can't see you all in person. I know I didn't have the beard in the picture that I was showing before, but you could all vote on your chat and see if I should shave or not. I'm happy to get some feedback. If I could have the next slide, and I'll, if I could spend a moment, just give you a little bit of background of, kind of, because I was sitting here listening to Brian and Jeff, who have been doing this for decades, and I'm like, what am I doing here? I'm an old Jersey boy, Morris County. To prove it, the only other job I've ever had besides healthcare was in a diner. I was a busboy, dishwasher. This is the org chart of a diner, by the way, for those who've never worked there. A busboy, dishwasher, short order cook, waiter. That only lasted a day for reasons I won't get into. And then I spent probably almost a decade as a short order cook. So every summer and every Christmas through high school, college, and medical school, that's what I did. As a medical student, I spent time up at St. Clair's in Denville, close to my home in Boonton, Dover General Hospital. I spent time in my residency. I trained in St. Joe's in Patterson. During that time, we spent some time in Newark. We spent 6 months at Hackensack. I spent a little time in Pascagoula Valley. So I'm pretty familiar, at least with the northern part of the state and those hospitals. And then my family actually moved down to the New Brunswick area. And as they were older, I started getting experience more from the patient side of what it was like in a lot of the hospitals throughout the central part of the state. That being said, how did I get here, or how did I get into the value? I'm a high risk OB guy. I mean, I delivered triplets and quadruplets for most of my career. I had an academic career at the University of Connecticut, full professor, thought board examiner. I kind of thought that's what I would be doing. And I got recruited to Stamford Hospital in Fairfield County as chair of the department. And it was a great opportunity for me. And I love the place. Frankly, I'd still be there if it wasn't a 150-mile commute round trip from my house. And 2 years after I got there, they asked me to become the chief medical officer, which is a job that I kind of knew didn't look like a fun job, and I really didn't want it. Didn't think I was qualified. But my boss at the time, the president, convinced me to do it. It was transformative for me. And it's a transformational job for most chief medical officers. It's a career change, let's be honest. And in a mid-sized hospital like Stamford, about 300-bed hospital, you end up getting a lot of stuff under you. So I was responsible for patient care quality, patient safety, risk management, as well as all the 10 department chairs reported to me directly, and patient experience. And all those things I realized started to blend together in my mind. That they're all variants on a theme. That hospital, and in full disclosure, was uninsurable. We became self-insured while I was there, and we couldn't get insurance in the reinsurance market in Lloyd's in London. So we had to go domestically, which actually cost a lot more. For those of you in that space, you appreciate what I'm saying. So it was my job to fix it, right? And it really had a lot of challenges on the safety and quality, patient experience, and patient satisfaction side. And over 8 years, we were able to really become one of the higher performing hospitals in Fairfield County, Connecticut. We were always a high cost provider. So, I had little impact on that part of the equation, but at least on the numerator, I thought, we should do better. And we did. By the time I was finished, when I go to London every year, they'd love our business, and we had, our rates went down, our premiums went down, and more importantly, we were delivering safer care to patients. So that was a very transformative experience for me. And I learned a lot about most of what I'm going to talk about today. There was a couple things that struck me then, though. One, at our competing hospital, a lot of my patients would have their hip replacements and knee replacements at a hospital down the road in Greenwich. And it was specifically one surgeon that seemed to get all the business. And a couple of my department chairs actually went to the competing hospital, which kind of makes you crazy when you're a chief medical officer. I'm like, why are you going there? I said, oh, Dr. X, he's a great surgeon. So I started looking up Dr. X's qualifications, and he was had general training, nothing really special. He'd never done an arthroplasty fellowship. And I would tell some of my colleagues, I'd say, we have 3 arthroplasty trained fellowship trained surgeons on our staff. Why don't you go to them? And it was the early seed that was planted in my head of how people make healthcare decisions. Even informed folks like department chairs were still basically going by word of mouth, colleagues that had gone and had good outcomes. So I'm not saying the person had bad outcomes, but it really kind of taught me a little bit about, and it was introduced me to the whole behavioral economics of how people make healthcare decisions. So with that as a preamble, let me move into the presentation. So next slide, please. So, we've talked about the RAND report, and this is very important. At the end of the presentation, you'll have a link to the RAND report. I really would urge everyone, specifically the providers and the hospital systems on the phone here on the call, to read it carefully. This was the first study the RAND did in 2017 with just an employer group from Indiana, and they looked at prices for hospital services throughout the state. They made comparisons by benchmark against Medicare, because that was a number they could use to compare one hospital to the other as a denominator, and they reported hospital-specific prices. And what they showed then was a tremendous variability. The RAND 3.0, which is now the two editions later report that I'll be referring to, includes now it's a much more robust data set. It was 120 self-insured employers with anywhere from 100 to more than 100,000 employees. So we're talking about millions and millions of claims over 2 years, from 2016 to 2018, a little more than 2 years actually. And also included in that were 11 state employee health plans. And as Jeff alluded to, as you all know, in most states, the state employees are either the first or the number 1 or the number 2 large employee set. It also included 6 all-player claims data from 6 other states. So there's a ton of data. All in, it was about $34 billion of healthcare costs. So I think we can argue all day about the data, but it's a pretty robust data set. And what they did is they sliced and diced it, basically, as you heard Jeff allude to, overall hospitals quality using a few measures. And I took that and kind of expanded on it to make it a little more, I would say, robust regarding the quality. Because quality in healthcare is one of those things we all have, what's quality? And I tried to define it. I kind of knew it wasn't intuitively, but how do you objectively talk about quality, safety, and patient experience? Next slide, please. So, these are the parameters I consider, the ones I've used that I tried to benchmark my own hospitals against. After I left Stanford, I got recruited to St. Francis, which is a 600-bed level 1 trauma center. It's one of 3 level 1 trauma centers in the state of Connecticut. It was about $1 billion annual revenue. I had about 5,000 employees. And, it was interesting. Unlike Stanford, St. Francis was already a low-cost provider. So I knew that going into it, which, by the way, I was never really, when the boss used to say, oh, we're a low-cost provider, I didn't really think that was a great thing. I just thought they never leveraged their market presence to negotiate better prices. Well, let's face it, that's what most people do, right? So I figured, okay, they're already low cost, so my job is to raise the bar on the numerator of the value equation that Brian was talking about, the quality measures. So I looked at the hospital objectively on quality measures that I was very familiar with by this point because of my prior experience, whether it's patient safety using Leapfrog, whether it's HCAP scores, likelihood to recommend the hospital, patient experience scores by Press-Ganey surveys, where we were regarding any of the national ranking bodies. And, to be fair, we were kind of mediocre. I was only chairman for 2 years, unfortunately, which, by the way, chair of a community teaching hospital is the best gig you can get in healthcare. And they asked me to become the chief operating officer and chief physician executive. I replaced 2 people one day, pretty challenging thing to do. So I had all these things, once again, all under me. And I really made it my personal mission over the ensuing 8 years, of which the last 5 years I became the president of the hospital, to raise the bar for all of those measures. And, by the time I was done, and Jeff alluded to this, and I say this proudly, we were one of the top performer hospitals in the state in every one of these measures. So I'm just going to talk about each of these a little more detail so that, and again, I think many of you are probably pretty informed on these measures, so, bear with me. So the Leapfrog group, what's that about? So back in, just a little more than 20 years ago now, the Institute of Medicine wrote a book called To Err is Human. And what they reported then was that about 44,000 people die in hospitals every year from preventable errors. And I remember actually reading that book and reading it was big news at the time. I wasn't really totally surprised by that number, to be honest with you, because, as a subspecialist, I'd kind of seen plenty of mistakes over the years. And people reanalyze that data and actually think the number is closer to 100,000 and maybe even more, which makes preventable deaths in a hospital one of the top 10 causes of death in this country. So the Fortune 100 companies and other provider groups at the time kind of freaked out. They said, oh my God, people are dying in these hospitals. We need to let our employees know where, safer hospitals are. So they created this not-for-profit arm called the Leapfrog Group, who really analyzed 28 different measures of different that hospitals themselves provide, by the way. So they don't make the numbers up, and really started grading hospitals from an A through F grade, just like you would get in school. And by the way, New Jersey's doing pretty good. They just spring of 2021 data shows New Jersey ranks 14th, I think, in the country, and about 38% of the hospitals in the state are A rated, which is, by the way, much better than Connecticut, which is, I think, ranked 29th. We had 7 A's in a row when I left St. Francis. The scoring comes out every 6 months, so that's 3.5 years of straight A's. But my competitor across town got straight C's during that same period of time, and once again, I was frustrated by I knew we were low cost. I knew we were safer. Why do folks choose to go there for, let's say, elective procedures to my hospital, which again goes back to the behavioral economics. So anyway, we'll use the Leapfrog Group data when we compare hospitals in this state. And just to put in for the non-healthcare folks, just to put in some perspective, what this means. The chance of dying in a hospital with a D or F rating on a patient safety score or getting a serious hospital-acquired infection or condition is twice as high in a hospital with D or F than an A hospital. And even healthcare executives actually don't really recognize that number. And it's just math. Patient engagement, HCAHPS, which is Hospital Consumer Assessment of Healthcare Providers and Services, which only the government would come up with an acronym like that. But you're all familiar with this. These are questions that are asked, really piggybacked on top of our Press Ganey surveys. And they really survey patients about things like communication with doctors, communication with nurses, also things like, was the hospital quiet at night? Was the room clean? And then, of course, there's some outcome measures like, did people develop a fall? Did you fall, get injured, or was there a hospital-acquired infection developed? So they use those measures to rate hospitals. And I use the likelihood to recommend score, which kind of is an all-encapsulating number. And there was one that I personally, as a hospital president, I strove to get a very high number in that. The median, by the way, for likelihood to recommend around the country is about 71% of people are likely to recommend the hospital. By the time I left, we were about 82% of people are likely to recommend, which may not seem like that much of a difference, but there was only one other hospital in the state that did a little better than us at that point. And they were a smaller community hospital. I would argue it's hard for a level 1 major teaching center, where the major teaching hospital for the University of Connecticut and the Frank Netter School at Quinnipiac to really do it. So we were able to achieve that. Patient satisfaction is straightforward. Most of you use Press Ganey probably surveys. I'm sure most of you have been patients at some point. You get a survey within a week or two. You might get a phone call or electronic survey. Most of it is still done by mail. And you're asked about your experience in the hospital. And then patient-reported outcomes. Brian alluded to this, and I would say this is why I think this should be the most important measure. Unfortunately, there's really not a lot of good data about patient-reported outcomes. And what's the difference between these other measures I've just talked about, patient-reported outcomes? I'll use orthopedics, even though I'm an OBGYN. Frankly, I know much more about cost and quality in orthopedics because we had a major orthopedic center in my hospital. We did about 300 hip or knee replacements a month, or more than 3,000 a year, one of the largest in the country, actually. And I would argue one of the best. I mean, Consumer Reports rate us in the top 5 in the country, which for both hip and knee replacements. So, if you have a problem with it, ask them, how that happened. But, because we had a team of surgeons who actually would sit around the room with each other and could compare the outcomes, because we spent $1 million, the hospital spent $1 million to create an entire team to get outcomes on patients for up to a year after they hip and knee replacement. We had about 95% ascertainment. We really hunted these people down. How are you doing? Real things that matter to people. When did you were able to get back to work? When was your pain alleviated? When were you able to golf or tennis or walk or whatever the things are important to the patient? Outcomes that matter to patients, not outcomes that we in healthcare traditionally looked at, like, did you get readmitted in 30 days, or did you die, or did you develop a serious infection? Those are things that are really important. Truthfully, there's still, I would say, a paucity of data about patient-reported outcomes. And then finally, we'll allude to some of the national, kind of international rankings that exist out there. So we were a top 100 hospital by IBM Watson. IBM Watson really uses a combination of all the things I've just talked about. Also looks at the financial stability of the hospital, which when you think about is actually a very important thing, and also includes, of course, the patient experience in that. So we were the only hospital in the state of Connecticut that's in that group. Just for those of you not familiar with IBM Watson, there's entire states that don't have any hospital. Actually, New York, Maine, Rhode Island, Vermont, New Hampshire don't have, there's only one hospital in Connecticut, in New Jersey, excuse me, and I'll call them out only because they know it, and the rest of you probably do too, is Morristown Memorial is the only hospital in this state that actually made that list. Newsweek, I got a call one day, my assistant called me and said, Newsweek's on the phone. I'm like, yeah, right. And I said, let me guess, they want my credit card number? And she said, no, they're calling to say you're, something good. I said, okay. I got them on the phone and they said, we want to congratulate you for being a top 1,000 hospital in the world, which I actually didn't even know was a thing at the time. And we're on that list now the last 3 times. And at that time, I think we were number 186 the first time, which was pretty cool. There were only a couple of hospitals in the state that were on that list. Now, all of these lists and things use similar data. And then finally, I mentioned the CMS star rating. CMS uses a lot of this information with a lot of different 50 some odd measures, 57 different measures to rate hospitals. And the average hospital has about 37 data elements in there, and they rate from 1 to 5 stars, 5 stars being the best. So I use all of this in my analysis of the hospitals, and I got the cost data from the RAND report. Next slide, please. So going back to RAND, what did they show? So not surprising, just like they showed in the RAND, 1.0 from Indiana, there was significant range of costs when they compared against the average Medicare payment. And we could argue it's the best measure for cost, right? Medicare, using an average Medicare payment is pretty good because it's a standard price. Medicare, as you guys know, sets the price for they pay. Medicare, there's a difference in payment to hospitals like ours, a teaching hospital. Many of you on the phone, I'm sure, are teaching hospitals. You get a little more money for Medicare. There's also wage index adjustment in there. There's disproportionate share if you take care of a lot of poor folks in there. But it's a pretty good denominator to have to compare apples to apples, if you will. And they also found a lot of variability of cost between hospitals in the same state, actually more than even in other states, which was actually very surprising. So you would think, okay, if you compare New Jersey to New York or Pennsylvania, you would expect that variability. But actually within the same state, there was actually more variability on a percentage basis. And then finally, there was even a lot of variability. And of course, in this state now, we've had a lot of consolidation. It's only a handful of health systems now that account for most of the hospitals. There's a lot of variability within the systems in the same state. Next slide, please. So, what's this all about at the end of the day? And listen, I've been around too long and I've been hearing about the move to value for seemingly forever, at least a decade. And I was like, yeah, right. I'll never see it in my lifetime. I really sincerely believe that. And I don't believe that anymore. I'm convinced that what you've heard from Jeff and Brian is real. It's happening throughout the country. Frankly, it's moving faster in other parts of the country than the Northeast, I would say, with a few exceptional pockets. But it's coming because no one's really happy with the system we have. We have to be honest with this. No one's willing to. Employers, I'll put on my employer hat for a minute. When my broker would come to us every year and talk about our costs, and I'm like, why are my healthcare costs going up 10% a year? And in all honesty, I would rather pass on some of that money to my employees. But, I couldn't because I was paying this ever rising healthcare cost. Nobody wants to do it anymore. Employers are sick and tired of it. And frankly, the patients, and I think, we alluded to consumerism. patients are tired of it. Next slide, please. So what did I do? And obviously the hospitals are not identified here. They would be on the far left column. But what I did was I looked at hospitals throughout the state. And by the way, I did this in Connecticut as well. So I was kind of curious, you know, how my hospital stood compared to the others. I tried to be as fair, I'll use that word, as possible, which means I included as many measures as I could. And I wanted to be careful not to use just a single measure when I could. So for example, I used the last 2 years of leapfrog grades, which is why you see 4 grades in a row. The most recent one would be the far left, going to the one 2 years ago would be to the right. And I gave a point score of 25 points for every A somebody had over that 2-year period of time. Now, why did I choose 2 years? You know, I could have chosen 3, or I could have chosen 1. Smaller hospitals in particular, and my system had 5 hospitals. I actually had responsibility for 3. And one of them was a smaller hospital, had an average daily census of 40, a 60-bed hospital. And, you know, I saw that hospital go from A to C from year to year, or 6 months to 6 months, because of just a few falls and injuries or a few infections, MRSA infections, or C. diff would flip the hospital to a C from an A. So I thought to use just 1 grade really wasn't fair. And as I have alluded to, you know, we had 7 A's in a row. If you're really going to change the quality and safety in a hospital, it's a cultural transformation. It becomes hardwired, where you see on this list, you see a bunch of hospitals get A's, or maybe an occasional B in there. So I used four scores, 2 years worth, and I then turned it into a single number based on a weighting. CMS scores, I use the star rating, and I transferred this 5-star system into a point system. So you see a hospital near the top there got 5 stars, so they get 100 points. I use the patient survey score. I use the single score of the likelihood to recommend, which is also there were no number 5s on this. So again, I gave points, 25 points for every score. And then I basically averaged simple arithmetic mean. Again, we could argue how much this should be weighted one way or the other, but I did a simple arithmetic mean of what we'll call a composite quality score. The next column is the cost. And what I did here was take the average cost compared to the Medicare cost for overall for the hospital. And again, remember, these are not specific to specific services. This is overall rolled up. So it's not to say a hospital that's very expensive overall is expensive in all areas, nor is it true that a hospital that looks less expensive might have some very high cost areas as well. So this is just overall hospital numbers. And then I created basically, again, simple math. You know, I'm an old math major, but I kept it simple. It's basically just numerator over denominator, quality over cost, and you come up with what I call the value index. And you can see there's a spread. And this is, of course, not all the hospitals in the state. As you guys know, you have many hospitals in the state, more than 70 that I rated here. You'll notice there's some red numbers down towards the bottom. A few hospitals didn't have cost data in the RAND report, probably because they just didn't have enough numbers. So what I did for them, because I didn't want to leave them off the list, I didn't think that was fair. So I just took the mean of the total of the average cost for the state of Connecticut. Excuse me, I keep saying Connecticut, the state of New Jersey, and picked that number. I did the same on the composite quality score. Again, we could argue, is the methodology okay for those? You know, I could just knock them out of the list, but I didn't think that was fair. On the far right, I just put some of the other, I didn't use these rankings on the right side, but I just wanted to show, you know, directionally, I was kind of surprised, I was actually pleased, I guess, to see that directionally they seem to be right. So the U.S. News and World Report, which I'm not necessarily a big fan of myself, although I was on their list too. The reason I don't like them as much is because they only count either, if you look at the weighting of all these scores, and I without getting too granular, but I'll admit I'm a little anal on this, without getting too granular, they use only 7.5% of their total weighted score is patient experience, which seems like really underrepresentation of the patient's experience in a hospital. On the other hand, their single heaviest weighted thing is, do doctors recommend the hospital? Now, and I would love to tell you that doctors really know where good hospitals are or know any of the stuff I'm saying, but at least in my experience, most doctors actually don't know most of what I've talked about. I don't mean that in an arrogant way. It's just the reality. I didn't know anything about it either until I studied it. You know, some of my competitors would actually send. So the way that information comes out is through Doximity, which is a physician survey electronic email tool. And they would send emails to the docs and say, hey, you're going to get surveyed by Doc Cindy next week on where's the best OBGYN hospital. Please rank us highly. Well, so guess what? The large hospitals that had a large employed physician group in particular always ended up looking big. So the U.S. News and World Report really does favor, in general, larger hospitals that can influence the score a little bit more. So I'm going to stop and go to the next slide, and we're going to turn it back to Jeff at this point. So I just want to conclude by saying, I think, change is upon us. Not all of us embrace it. I did. I thought, I was frustrated actually, because I was a value provider and I got frustrated by why are people, not using the information available. I'll just close by saying, I wrote a book during the pandemic, which if there's any agents on the call here, please notify me because I haven't gotten it published yet, but trying to educate consumers because I continue to be amazed how people make healthcare choices and decisions. Because this data that I talked about is all publicly available, but it's not easy to navigate. It's not easy to find. And frankly, most people don't do it. And most people don't, I'll use the hip replacement again as the standard. I think most people have hip replacement, either ask their golfing or tennis partner who did your hip, or they'll ask their primary care physician who says, I refer to Dr. Jones. I would argue in most cases that primary care physician actually doesn't know much about Dr. Jones's, actually might not know much about their training and knows very little about their outcomes. And the sad part is Dr. Jones actually typically doesn't know a lot about their outcomes. That's just because how would they, unless they spent $1 million like I spent to get the data. And then, so I bought a TV for my daughter and I had this epiphany. I said, she wanted a flat screen TV and I went to Consumer Reports and I went to another consumer site and then I went to a big box store and I lined up the top 3 brands and then I probably bought it on Amazon and I installed the TV. And I'm thinking, wow, look how much work I did and effort for a $400 item at a time when I was making $1 million a year at that point. I'm like, really, it's $400 and I put that much effort into it. But if my friends and colleagues are in a similar situation, needed a hip replacement, they would ask their primary care physician, they'd say, go to Dr. Jones. You'd see Dr. Jones who would say, yep, you need a hip replacement. They'd do an x-ray probably, unless they owned an MRI, they'd get an MRI first. And they would say, Susie's going to call you and schedule it, and you'd be scheduled. You'll get a call from that hospital in a few days, booking it, and a day before your surgery, someone's going to call you and ask you questions, and then you're going to have the surgery. What's the difference? One costs $400, and if it fell off the wall, I'd be like, okay, got to buy a new one. The other one is a $50,000, and that price, by the way, is variable, but I'll just say $50,000 price that can actually kill you. Right? You could get a pulmonary embolism that's lethal. You can have a transfusion reaction. You can get transfused. You can have a readmission. A lot of bad things can happen to you, or you get a serious infection in your hip that will be, could be potentially, not just life-threatening, but alter your future. And you don't do any shopping. The average consumer does no shopping for that. So I'll end with that and say I think that time is changing. So thank you.
The next slide, please. Thanks, John. That was really helpful. We found in Connecticut, a group of us actually worked with the state of Connecticut Office of Health Strategy a year and a half ago to get the all payers claims database data into RAND for the first time ever. So Connecticut data appeared this past September in RAND for the first time ever. And as John was just indicating, people really didn't know what to do with it or how to deal with it and what have you. I remember getting a call from the First Lady in Connecticut because we, as a group, the Moving to Value Alliance, had just done a presentation after the release of RAND data to our group and kind of broke it down and found some really kind of striking and shocking things. I remember having a conversation with Vicki Veltri at the Office of Health Strategy about some things that we found. In fact, the state of Connecticut data showed us that Connecticut has an 18% complication rate for hysterectomies. That was a huge outlier compared to other states. And how do we drill down on that and get rid of that particular thing? A problem that exists here as elsewhere, vaginal deliveries range in price from about $7,000 to $21,000. It was just really quite striking to us and to others what this variation looked like. Was it higher quality or what have you? No, this was straight up variation. So as John was indicating, this has become really helpful, especially in Connecticut, elsewhere, Maine as well, to focus on those things. So MSK, cancer, cardiometabolic are typically the three biggest areas or cost drivers in an employer's health plan. Doesn't matter how big they are. The variation tends to be different, obviously, by employer and their demographic. But this opportunity to do better in these categories and other categories, we're even looking at other categories like autism in Connecticut for episodic center of excellence opportunities is a huge opportunity. One of the stakeholders yesterday in our breakout groups brought up a really good point. How do we deal with things like centers of excellence and networks of excellence, particularly in rural areas? I too was born at Morristown Memorial, lived in Randolph for a period of time, and the northwest corner was a playground for us. And clearly the southern part of the state is also very rural as well. In Connecticut, we've looked at this episode of care issue in two different ways, by creating a network of excellence and a center of excellence, earn-in, if you will. And this is really important, particularly for health systems and organizations who haven't done episodic targeted price things in the past. I'm not sure if John mentioned it or not, but part of the RAND data, and this is really important, is not just the variation in cost and quality in aggregate terms, but by service lines. This is publicly available information that a hospital may be a top performer in aggregate, but in specific service lines, cardiac, MSK, whatever the case might be, they may underperform or overperform as well. We found in various areas around the country, the network of excellence, hospitals that are rural may be huge outperformers for MSK and be the available mechanism for musculoskeletal steerage. So this is a nuanced program that has to be designed specifically for here, but the belief is, and looking at the data, there are plenty of high performers out there, both in state and out of state, who can help to enable this move to value. We put up again here this sample tactical navigation map to reiterate the paradigm, if you will, or a panacea, which uses tech-enabled advanced primary care, steering to high performers, just as a reminder from the beginning of the presentation as well. So could I have the next slide? So Ryan, John, myself, we've talked about advanced primary care. There are a lot of really good primary care organizations in the state, and we've seen, especially since COVID, the advancement of the primary care model or a paradigm. One of the pieces that's at the end in the appendix of our presentation is a piece from the Primary Care Collaborative. They actually worked with what was the Pacific Business Group on Health, which is now the Purchasers Business Group on Health, and the National Alliance of Healthcare Purchasers Coalition to come out with a paradigm model. It was actually issued on December 1st of last year of what the paradigm tech-enabled advanced primary care model looks like. Many of those items are included here. Enhanced access, which means access in person and virtually, interoperably, with longitudinal care coordination at risk, great patient engagement tools, accountability, which means getting rated on performance, this whole notion of health improvement, integrated behavioral, and the ability and opportunity to steer. So in the past, that hasn't necessarily been a big thing. We've seen large organizations and even smaller organizations at this point figure out the fact that using attributed at-risk primary care steering to high-performance providers is a winner, getting rid of fragmentation, and we see examples of that around the country. Next slide. So here I'm going to use some examples of things that we've seen, successes in the marketplace that use some of the tactics that we've been describing in the presentation below. This is a company, it's a tri-state company, it's Connecticut, New York, and New Jersey. It's a high-end supermarket chain that had been 10 years self-funded with Cigna, about 2,000 employees. This employer is really well known for their culture, for keeping people, for being very consumer oriented, and their leadership had joined our Moving to Value group about 4 years ago and had become very active. And the owner of this organization, about a year and a half ago, said, time to put our money where our mouth is. I'm sick of paying these numbers. I want to pay my people better. I want a better plan. So what they did is to pick a pair, and they actually used a third-party administrator. They required attribution tech-enabled advanced primary care election, and they did direct contracting and steered to high-performance providers in Connecticut, New York, and New Jersey. And upon their renewal, their claim pick went down by 35%. So they did direct contracting. They also did very, I wouldn't call it aggressive pharmacy management, more efficacious use of drugs and changes in site of care, particularly on med pharmacy and what have you. And again, the advanced primary care attribution. And they are living proof that this can happen. In fact, they are very happy to proselytize their message out to other employers and purchasers, and they have and are in the marketplace talking about how they did this, and they did it in 1 year. And the employee satisfaction on these plans is in the mid-90s. Next slide. So I alluded to this earlier in the presentation. I want to talk to you about it a little bit more here. In fact, there are some folks on the phone who embody some of these point solutions and some of these tactics and are working here in New Jersey already to bring health tech to what I would call legacy provider groups and health systems to help them do care transformation. This is so important. We've had billions of dollars pour into health technology in the last couple of years to do just this, to meet these new expectations. And in many ways, it's disrupting our health systems in general. So the first example is a national company, and I'm not going to call out the company, but basically put together a business model that Uberizes much of emergency care and urgent care as well. In simple terms, employees have access to an app, generally within an hour, for most things that they might use emergency room or urgent care facility for. Generally within an hour, a PA or APRN shows up at their house. They're equipped with all kinds of stuff, including x-rays, and can treat that patient for many of the things that emergency rooms and urgent care facilities do for a fraction of the cost using an episodic pricing mechanism. They are par. We're contracted with the big book of payers. Their net promoter scores are basically 96. So people really like them. And, obviously this got accelerated with COVID, where people didn't want to wait in an emergency room or an urgent care facility for fear. But this organization will be in 50 states by the end of the year, and has had just huge take up, and likely will leverage their model to be doing things like steerage. They are already doing things like apportioning primary care to patients who don't have a primary care physician when they discover it on scene. We know for a fact throughout New England that this organization has disrupted some of the hospital systems. In our area, we have hospital systems trying to create their own type of system that mimics this because of the disruption. So this is a health technology company. The next organization here really has done the digital front door in a masterful fashion. And in this case, and they're on the phone, I won't call them out, but work with OBs basically to create the front end engagement model and superior care coordination, the check-in with the OB once there's a pregnancy, to follow that patient, to interact with them, to provide them with education, and also to ping back into the EMR and the EHR in a very simple consumer-centric way. This has taken off dramatically. Most of you are clearly aware that the OB is the advanced primary care physician for women of childbearing age, and this is a brilliant use of technology to leverage and move to meet these new expectations in the marketplace. And then there are a whole host of companies that do digital therapeutics. We've talked about advanced primary care. We've talked about high performance providers and specialists and health systems here, but we're finding really the critical thing to bring this closed loop of accountability together are things like digital therapeutics. For example, in the state of Connecticut, they knew that they were spending about $3 million a year on sprained ankles. And why? Because people with a sprained ankle were going to the emergency room for an average cost north of $2,500. And they've created, as part of the care path, as part of their plan design, incentives to get assessed by a physical therapist or another digital therapeutic mechanism using trainers and things of this nature, and using an appropriate site of administration, bringing their cost down to about $200 to $250 for that sprained ankle versus $2,500 or $2,600. There are other digital therapeutic companies out there already operating in the state, doing great things on the behavioral side, and many other services. And this is an opportunity or an offer to those of you who are on the phone to partner with some technology companies and others to create that nuanced care path. We're particularly disturbed, and we've found this around the country as well. Clearly, cancer is one of the big things in every plan, and we've seen huge variation in cost and quality and outcomes for cancer. And we learned from a New Jersey company surveying internationally that about 73% of people diagnosed with cancer never get a second opinion and end up either with the wrong diagnosis or on the wrong care path and with poor outcomes. And we now know that there are digital therapeutics, there are digital diagnostics available as part of a nuanced care path to appropriately diagnose and indicate more appropriate care paths, be they immunology or otherwise. So this slide was meant to talk about health technology, but it was also meant to talk about what we might call the middleware from tech-enabled advanced primary care, steerage, nuanced care path, getting to that outcome and the right high-performance providers as well. Next slide. So we haven't spent a great deal of time on specialty drugs, but specialty drugs are a substantial, huge opportunity for the state of New Jersey and its health plan, having analyzed both PBM data and med pharmacy data as well. As many of you are on this call are aware, the drug that always comes out on top for the biggest spend, and this is international, is an anti-inflammatory that costs about $50,000 a year. And why are we focused on efficacy and outcomes? Why is that the most important? You know, many people say the cost of drugs, and we have to regulate the cost of drugs and things of this nature. And what's been discovered as part of this discussion, in fact, we were having this discussion with Dr. Rodis yesterday, is that physicians have pharmacological training in med school, but then they don't have any pharmacological training for the most part afterwards. And it's often really difficult, one, for a provider to know the cost of the drug, and two, the FDA endpoints or goals for the drug. Really difficult to bring those things together. So here we have a drug that costs about 50 grand a year, and that we know that roughly 49% of the patients have a poor outcome from it, and only about 10% of the patients have a great outcome from it. And that's really curious. Why? Because it's hard to see what the outcomes are for specific specialty drugs. Why would we continue to pay $50,000 a year for a drug that has no outcome or a poor outcome? And why wouldn't we alternatively look at drugs, similar drugs, biosimilar drugs that start at around $5,000 that perhaps have fewer side effects and are more efficacious? So that's meant to be a rhetorical question for you, and that's why this is a target. Specialty drugs are a target because of the expense of them and potentially the lack of efficacious treatment as an opportunity for getting better outcomes on cost and quality. Next slide. So as I mentioned to all of you earlier, this is a listing of the resources and citations that we used in the analytics for this presentation. The presentation will be available. These are hyperlinks as well that will take you to them as well. Next slide. So what's next? As I said at the beginning of this presentation, the Division of Pension and Benefits gave us the opportunity to talk to folks, to look at data, to speak to the stakeholders. It's clear there are great health systems in the state. There are great providers. There are terrific folks that can help to do things differently. And that really is the opportunity for this health plan at this point, to embrace the data, to embrace the opportunity, and to hear from those out there, you, who are potentially interested in partnering with them to reduce variation in cost and quality, to increase access, and to provide for better outcomes in general. We are entirely grateful to you for taking the opportunity to speak with us today, and we will have breakout sessions this afternoon. I encourage you to meet us in those breakout sessions, and so that we can take up more of a dialogue with you. Nikki, anything to add?
Thank you so much. So yes, as stated earlier, we do have 2 breakout rooms scheduled. One for 12:30 to 1:30, that is for primary care providers. The second breakout room is scheduled from 2 to 3, and that is for health systems. If you do need to have the links, I am going to ask you to please make a comment in the chat here, and then I can certainly resend the links if needed. And if you have any questions or have any issues with getting into this, you can certainly also email to me. I am the person who sent the email last night. Thank you.
Very good. Thank you for joining us this morning, and look forward to engaging with you this afternoon. Thank you.